All right. Hello and welcome. My name is Wenzel Lewis. I use he, him pronouns, and I'm a program operations specialist with the University of Washington CoLab for Community and Behavioral Health Policy. CoLab is a youth wellness think tank housed within the University of Washington Department of Psychiatry and Behavioral Sciences, and we engage community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly those involving youth and families. Today's webinar is titled Bringing Specialty Clinical Skills to Youth Mobile Crisis Response and Stabilization Teams, Experiences from a Collaborative Consultation Training Program. We've convened a great panel of youth mobile crisis response and stabilization staff across Washington State to discuss this multi-year effort to equip teams with evidence-based strategies for supporting high-risk youth and families. You can go ahead and move to the next slide, Krill. Thank you. Before we get into today's discussion, CoLab for Community and Behavioral Health Policy and the University of Washington would like to acknowledge that there are 29 federally recognized and 7 non-federally recognized tribes within Washington State. Within Seattle, where CoLab is located, we acknowledge the Coast Salish peoples of this land in Seattle, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. As we move forward in advocating for and moving towards health and racial equity, let us remember that we are living in a history-driven present. Let us learn more about the histories, cultures, and traditions of Indigenous people, how we might build relationships in sovereign tribal nations, and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult native-land.ca to learn more. That's native-land.ca. And thank you to Native Land for providing these figures. You can go to the next slide, Krill. All right, so we have a great discussion prepared for you all today and want to make sure that you are able to fully participate. Please use the chat function highlighted in red here to message our team if you're having any difficulties navigating Zoom. Be happy to help you out. Use the Q&A function to submit questions you may have for CoLab and or the panelists present for today's call. Submit those questions at any time and we'll try to answer as many as we can during the Q&A portion at the end of today's call. All right, you can go to the next slide. With that, I'm going to pass it off to Dr. Robin Metcalf, who's going to lead us through a mindfulness exercise. So you can take it away, Robin.
Hi, my name is Robin Metcalf, she, her pronouns, and I'm a postdoc here at CoLab, and I was part of the training team. So before we get started talking about our work, we're going to do a little mindfulness activity. And some folks may have heard of mindfulness before, have different types of experience with it. For a lot of people, what people imagine is like kind of like meditating on a rock. And you can absolutely do mindfulness by meditating on a rock. But really what we mean when we say mindfulness today is just intentional, non-judgmental attention to the present moment. We practice mindfulness because it really helps us experience reality as it actually is, and also helps us be more in control of our minds. So for our teens who are in a crisis, which we'll talk much more about later, really the ability to do this helps underlie the ability to do lots of other skillful things that helps them get through this crisis and start building a life that they actually want to have. So I'm going to ask you guys to practice, and to practice, I'm going to have you just find an object near you, something on your desk. Don't overthink it. Maybe something you've seen a million times before. It can be a pen, it can be your headphones, it can be your computer mouse, just something familiar that is easy to grab. Don't overthink it, just pick something. And once you found that object, I'm going to ask you to approach it with what we call beginner's mind. So really looking at it as if you're seeing it right now for the first time. So using just your sense of sight, gaze at your object. No need to add words to your experience. Just focusing on the input you're getting from your senses. Feel free to turn it around and look at it from all sides. Notice anything you can see that you don't normally look at. If you find your mind wandering, that's totally natural. Just turn your attention back to just your sense of sight. Now I'm going to have you transition to your sense of touch. Run your fingertips along your object and notice the sensation in your fingertips. Notice any differences in the sensations you experience touching different parts of your object, or using a different part of your hand to touch your object. The goal is to experience the sensation without judging it as good or bad, just noticing the sensory experience. We're going to transition to our sense of hearing. Tap your object lightly with your fingers and focus on just what you can hear. Notice the different sounds you can hear as you tap or touch your object. Now hold your object to your nose and inhale, noticing any sense you can observe. Again, no need to add words to your experience, just focusing on the sensory experience itself. If you have an object that makes sense to taste, you're welcome to turn your attention to taste. You can also imagine what it would taste like if you were to taste it. Otherwise, continue to just focus on your sense of smell. That's fine too. I'm going to pull us back together. Thank you so much for practicing that with me. And I know people may have different levels of experience with mindfulness or different perceptions of it. So that might be familiar to some people, might be totally unfamiliar to other people. That's totally fine. If you notice that you got distracted at any point in that, but you pulled yourself back to the activity and were able to go back to focusing on your senses, that is one, completely normal, and actually also what the research tells us about mindfulness that's helpful, that process of coming back to it. So if you did that, you did it absolutely right. So thank you for trying and being willing to do something that might be different for some folks today. And I'm going to go ahead and turn it over to Kirill for some introductions.
All right. Well, thank you, Robin, for taking us through that. So we're going to start with introductions. Robin, thanks for introducing yourself. I'll introduce myself. Hello, everybody. My name is Kirill Gerdavenko. I'm a clinical psychologist. I'm an assistant professor at the University of Washington in the psychiatry department in the School of Medicine. And at CoLab, I'm the director of community clinical training and scale. And I'm also an attending psychologist and the director of the Seattle Children's Hospital Dialectical Behavior Therapy Clinic. And really happy to be here with everybody today. I'm going to pass over to Carlos for an introduction.
Hi, everyone. My name is Carlos. I'm a postdoctoral fellow at Seattle Children's Research Institute, and I'm also affiliated with the University of Washington through my work with CoLab that I'm here for today. And I was part of the training team with Kirill, Robin, and Winslow. Next, I will pass it on to the next person. I'll pass it on to Dwayne.
Hi, I'm Dwayne Krishke. I'm a mental health clinician in Spokane County, and I was part of the program and one of the panelists here. We'll pass it on to Dan.
Hi, my name is Danielle Maragos. I am a peer support specialist with the Children, Youth, and Family Mobile Crisis Team through Frontier Behavioral Health out of Spokane County. It's nice to see you all, and it's good to be here. I'll pass it over to Katie.
Hi, I'm Katie. I'm a crisis clinician / counselor out of Pierce County. with Seneca Family of Agencies. And I will pass it to Lindsay.
Hello, I'm Lindsay. I am a social worker and a supervisor for our mobile crisis team in Spokane County out of Frontier Behavioral Health. And I'm not sure who hasn't been introduced yet.
I think that's all of us. So thank you so much for introducing yourself, folks.
Great, great. Great group of folks here. Here's what we're going to cover today. I'm going to talk a little bit about the project background and progress. We'll try to dedicate much of today for a panel discussion with our wonderful panelists here, and then we'll briefly share next steps and cover a little bit of time, as Winslow said, for Q&A. So without further ado, I'm going to launch us in. First off, huge thank you to our collaborators and partners, especially our healthcare authority partners, some of them whose names are up here and many more that aren't listed probably. And of course, our behavioral health agency leaders and MRSS teams, Seneca Family of Agencies, Frontier Behavioral Health, and Catholic Community Services. And some of these wonderful folks are here for our panel today, so thank you. And then, of course, SAMHSA for the funding support, without which this would not be possible. So a little bit about the project background. Washington State, we know, experiences shortages in specialty mental health force, especially those tasked with supporting really complex, high-risk youth and their families. And although there are good, well-developed treatments and interventions for this population, many existing best practice care models are simply too expensive, too rigid, or otherwise infeasible to implement across the continuum of service contexts and care needs. Mobile response and stabilization services, or MRSS, as you're going to hear us refer to this, is a model that's specifically designed to create more timely and flexible access to care for youth across Washington state. And MRSS rollout has been happening around the state for a while now in an effort to sort of reform and improve mental health, the mental health picture in our state. And so this MRSS rollout really presented an opportunity to infuse this service structure with improvements such as further high quality evidence-based clinical content and skills. So we're really talking about evidence-based treatments, sort of leading evidence-based treatments for complex youth, such as dialectical behavior therapy or DBT, other commonly recommended treatments such as behavioral parent management training or PMT, cognitive behavioral types of therapies, motivational interviewing, that just kind of scratches the surface of the evidence-based kind of strategies and interventions that are often helpful for serving this population. So our broad aim with this project was really to co-design and implement a flexible modular skills training consultation model, specifically in this case for MRSS teams, based on leading evidence-based practices to support high-risk youth and families as best as possible in the state, right, within the service structure of MRSS. Here's a little bit about the project timeline. Back in March of 2021, meetings began between our HCA partners, CoLab, and Seattle Children's staff. By September 2022, we were lucky enough to receive SAMHSA funding to support training development for MRSS teams as part of this broader system of care grant that's related to the MRSS rollout in the state. Around February of 2023, we were really focused on beginning information gathering, needs assessment, and starting the co-design collaboration with our partner sites. I'll talk a little bit more about co-design on the next couple slides. By February 2024, our team had settled on both a sort of program format, as well as starting to identify priorities for program content, that we began piloting this integrated training consultation program with our three MRSS partner sites. And as of April of this past year, or this current year, I guess, we completed the pilot delivery of our integrated consultation training sessions, which included 25 total trainings with about 3 MRSS partner teams. So that's the timeline to date. Just a few more things about mobile response and stabilization services. So MRSS is a rapid response, home and community-based crisis intervention model that's customized to meet the needs of children, youth, young adults, and their families. You can see in this image that MRSS really breaks down into two core components. There's the initial small circle, which is the crisis response phase of MRSS, which lasts about 24 to 70, up to 72 hours, and is focused really on meeting the family where they're at and de-escalating and stabilizing the immediate crisis, right, or the growing crisis. So the tasks here are really focused on de-escalation, more immediate assessment, and kind of safety planning with the youth or the client and their family. And then the broader circle here is that after the crisis response phase, you move into what's called the stabilization phase. And this includes up to 8 weeks of stabilization family-based care that is flexible and sort of, again, meets the families and the clients where they're at, and also includes referrals and case management to get the patient or the client and the families connected to community supports, right? So this is just kind of the structural elements of MRSS. Just a few more details about this model. This is a voluntary community-based intervention. Again, it's delivered in the home, work, school, or any other community setting where it's needed. Clients and families define the crisis in MRSS. Everybody is eligible. Nobody's excluded or screened out or turned away, right? Again, the clients and families define when they need the help, right? And one of the broad goals is to reduce, obviously, the use of emergency departments, law enforcement, or other more restrictive, costly interventions, okay, before they're needed. And there's a high emphasis on the client's natural supports and strengths, as well as peer support services as a core part of what helps clients feel supported and heal and make progress, right? And the MRSS model also includes some important coordination with medical and behavioral health services, both kind of in the moment and longer term. So that's the MRSS model. There's probably people on our panel that can share more and know much more about this model than I do, but I wanted to kind of set the stage a little bit there. So a little bit about our design approach for what we were working on with this project then. We took a collaborative co-design approach to developing our consultation training program for this MRSS service structure. Now, co-design is a process where multiple stakeholders, including users, are actively involved in the design and development of a product, service, or system. It's a participatory design approach where the goal is to create solutions that are more relevant, effective, sustainable, and ultimately satisfying for the people who will use them. Co-design involves bringing together diverse individuals with different backgrounds, knowledge, and skills, sometimes even from across different sectors, and having them working together to explore ideas, develop prototypes, and make decisions. So this is really the philosophical underpinning of our design approach at CoLab, especially on this project. And in this particular context, we were really trying to draw on three broad areas working together and in tandem. So, of course, evidence-based practices, clinical content expertise, and maybe most importantly, community experience and wisdom. And so through this process, we landed on the following program structure, okay? The program structure was flexible and modular ongoing training series. So rather than doing just a single long training, we realized it would be much more useful to do a kind of a training consultation series that allowed us to sort of have an ongoing process, right? The series ended up in the pilot phase breaking into 9 separate sessions, about 90 minutes each, delivered at about a cadence of once a month. And we really tried to choose this structure or format because we found that it would allow us to kind of tune in and deliver this in a context to our MRSS teams that they already relied on during just 90-minute periods where MRSS teams are already in consultation and in team meetings, so that it required minimal sort of additional burden to coordinate and pull them away from their important work or their kind of daily workflows and routines. The actual sessions included a blend of evidence-based practice, training, and consultation delivered in hopefully what was a sustainable, digestible, and engaging format for our teams. And we used consistent refinement of the model based on constant monthly feedback from our MRSS team collaborators. So after every session, we would sort of openly ask for feedback, both through post-training surveys as well as just kind of throughout the process. And we tried to really look at that feedback and their experiences closely between each session and really kind of build as we went during the pilot phase. A little bit more about the design approach, because this gets really kind of confusing and challenging when you're trying to integrate so many different important sources of information. So, how did we arrive at the pilot program? This is my best effort at trying to visualize this. So, we began obviously with the broad care needs in Washington State, which I've talked about. We referenced and tried to really work with broader policy and systems efforts that were already underway. We turned, of course, to research and expert informed best practices, then kind of integrated some of those things as we now brought this to learn from and hear about community behavioral health experts, workflows, priorities, and their wisdom. That ultimately allowed us to define a feasible consultation training format that would work and sort of integrate knowledge across these different spaces. From there, we went into deeper co-design with our MRSS teams and staff to actually then co-design the consultation training content after the format had been decided. And that helped us ultimately land on what you're going to see us describe, which is the integrated training consultation pilot program. Now, if I was being honest, of course, there would be or more honest, there would be way more arrows that would be moving backwards and leaping across these different shapes and areas because this process of integrating all these streams of thought is anything but linear. But this is my best effort to show how we tried to sort of proceed through this process and through this timeline to integrate across these different areas. So just a little bit more about the content design process once we were looking at actually choosing the content. With our MRSS partners, we used a lot of live polling in our early discussions and throughout the pilot program. We first wanted to, of course, tune in to their relative interest and priority across these two different domains. So were they more interested in more emphasis on consultation around this work? Or were they more interested in some of the training and trying to calibrate the relative weight of what we were developing in response to that? And then, as you saw, the MRSS phases are the initial crisis response and the stabilization phase. So we were also trying to really tune into which areas seem to be most interesting and most relevant and high priority for our teams for further supports, tools, ideas to help them do this work. And then once we kind of had some feedback about that, we presented a fairly broad menu. This is just one of many sort of lists of various active ingredients of common evidence-based practices that may be relevant for this population. And we asked them to kind of rate their relative interest and importance of these various tools and tasks that they're trying to accomplish with a lot of these families and clients. And as you can see, was a lot of interest in a lot of these things, with one of the emerging patterns being that distress tolerance and emotion regulation skills for youth and caregivers being kind of one of the leading areas of interest across our partner sites. So this was really nice to see because ultimately it allowed us to pull almost exclusively from dialectical behavior therapy, where if there's DBT folks in the audience, you already know emotion regulation and distress tolerance are two of kind of the core active skills training modules in that intervention approach. So what the content, now I'm going to show this next slide and there's going to be a lot of text on it. Please don't feel inspired to read it all. I'm just sort of showing you on the next two slides the range of the many skills that we covered in our pilot program and sort of what is made up of these emotion regulation and distress tolerance modules. So our emotion regulation skills, for example, was again, if you know DBT, you're probably seeing this and going, oh yeah, these are like the core active ingredients of DBT, especially the emotion regulation skills module, which we know more and more with emerging research is kind of what makes that treatment really work and tick, so to speak. So we had things like For example, a whole module of skills on knowing and understanding your emotions, right? Which was all about learning and staying mindful of why you have emotions and how they actually can help you, learning to better understand and listen to your emotions so that you can decide what to do with them and helping them work for you rather than against you, all the way to kind of more complex skills such as the Cope Ahead skill, which really harnesses the power of sort of imaginal exposure techniques and strategies to help decrease anxiety and other emotions, both in the moment and for future upcoming challenging situations. So this is just like a menu of most of the skills that we covered in our emotion regulation section. And then our distress tolerance skills section also included a lot of things, such as kind of maybe one of the most novel and powerful DBT skills, the tip skill, which is all about hacking your body and physiology really quickly to kick in your parasympathetic nervous system to help you get calm and more regulated. But also some of the more sort of acceptance-oriented skills and strategies, such as radical acceptance, right? Which we described as making room for the painful things that you cannot change in your life, gaining back freedom and energy by stopping the fight against painful things that aren't actually controllable, right? And channeling our energy into things we can make better and we can control. So just kind of wanted to show you the range of skills that we covered within these 9 pilot sessions and how those sort of played out. Just a little bit more about the training content, just to, again, bring to life what this looked like. Here's an image of our first 4 sessions in the pilot program that tends to cover the emotion regulation module. You can see how these skills are all connected and how they're split and delivered into separate sessions. And we really tried to be thoughtful in the design here so that on the one hand, for staff and team members that could sort of join and follow along with the whole 9 session series or even multiple sessions, the skills really built on themselves and integrated into a nice cohesive package. On the other hand, even if you dropped in on just 1 or 2 of the 9 sessions, hopefully our staff felt like they could still walk away with something cohesive, coherent, that was relevant for them to pick up and use pretty quickly with the families and clients that they serve. So they're all connected, but also highly modular and can be sort of delivered and learned in bite sizes, right? And just single sessions even. Here's just a few examples. So we ended up pulling together a 50, 60 page emotion regulation distress tolerance guidebook that our team members got. And it had everything from kind of the didactics and the learning and teaching of this content and skills. And it was written and designed in a way that you could kind of grab and go, right? You could kind of print this off or pull it up digitally and really look it over with clients, with families, with both, and kind of be learning and discussing and teaching and applying these skills and concepts straight from the get-go with very little prep, right? And there was visuals to help illustrate some of these skills and ideas. There was step-by-step descriptions about how do you actually implement some of these tools and skills. And then, of course, this guidebook also had our efforts to pull together sort of putting your skills and knowledge into action worksheets, right? So that the families could sort of get copies of this and work on this on their own, work on applying some of these things, track how it's going, to then follow up and discuss and troubleshoot. So I just wanted to show a little bit of how this looked and how we tried to sort of present some of this content. Okay. Uh, I'm almost done talking here and we'll go to our panel, but I wanted to just as a last effort to bring a little bit of this to life, I want to just read off a sample vignette here just to give you a sense of how we were envisioning this. So I'll read that off in just a sec here. Let me pull this up. Okay. So imagine a 17-year-old adolescent female. She's got a history of exposure to multiple traumatic events in her life, as well as a long history of struggling with depression and anxiety symptoms. Access to consistent quality mental health care has been difficult for her and the family. And in the past year, her symptoms have gotten so bad that she's not been able to attend school at all lately. As her peers begin to celebrate their graduations around this time of year, and many are preparing to go off to college, she feels increasing levels of guilt, shame, and distress about having, quote, not accomplished anything, feeling like a failure, feeling like she has, quote, already ruined her life. Her thoughts and urges for suicide and self-harm increase even more than usual. She starts saying things to her parents, saying concerning things like, there's no reason for me to be alive anymore. And when the parents find some bloodied bandages in her bathroom trash one morning, they realize it's time to call for help. They get connected to a local MRSS team who comes to their home that same day and does a wonderful job of assessing risk, completing an effective and individualized safety plan for her and the family, and stabilizing the growing mental health crisis the teenager and family are facing. Even during this crisis response phase, the MRSS team may draw on some brief new skills, such as the DBT tip skill. The teenager is intrigued and maybe even a little amused at the idea that the team's encouraging her to try dunking her face in a bowl of cold water as a way to prevent emotions from getting more overwhelming. They get through the crisis stabilization phase. The MRSS team then proceeds to provide several weeks of follow-up stabilization focused visits and care to the adolescent and family. These flexible therapeutic contacts make the family and adolescent feel cared for and less alone. The MRSS clinician uses an early stabilization session to offer some skills training to the adolescent and parents. They cover a couple of skills, the first being radical acceptance, which helps the teenager and family more mindfully accept and acknowledge the challenges of the academic and mental health situation they're in without fighting it or making it worse. Radical acceptance also makes way for teaching and practice of problem-solving skills and the cope ahead skill, which helps them in making proactive changes to get the teenager feeling better and back on track. They identify specific tasks and ideas, such as signing up for summer coursework and coping ahead with painful thoughts and emotions that may come up during these months while the adolescent is doing their best to get back to academics. The peer partner who the adolescent develops a quick bond with teaches and works together with her on the accumulating positive skill, which helps her explore and identify ways that she can still engage in meaningful and pleasurable activities, both short and long term over the summer, and not just feel bogged down by retaking this coursework and playing catch up. This plan helps give the teenager and family a little more hope and provides some small but important steps to work on to make things better. Finally, the stabilization MRSS team attends to the parents' specific needs. They help parents identify how their very understandable and intense fears and other emotions related to their daughter's safety get in the way of parenting the way that they want to. They review and tailor some of the emotion regulation skills, such as check the facts and opposite action for the parents, and give them specific ways to practice regulating and feeling more skillful and in control of their responses. Given that some of these skills were also taught and reviewed with the parents and the teenager together, parents also express appreciation for this new shared language that they're starting to build, that they plan to use to more directly coach and support their daughter when emotions hit in the future. They plan to carry some of what they've learned into their continued family therapy, which the MRSS team has connected them with as they near the end of the stabilization phase. Now, I think our panelists will probably agree that in reality, this is much more complex and not quite as neat and tidy as I've presented here. And I hope this sort of highlights just one example of how these tools in this program is intended to be sort of used in a modular, flexible way across the continuum of what our MRSS teams try to accomplish for families. So without further ado, I'm going to go ahead and I'm going to turn over to Carlos, who's going to get us started with our panel discussion. Thanks.
Hi, everyone. Just to reintroduce myself, I'm Carlos. I'm a postdoctoral fellow here at CoLab, and I'll be moderating this panel with my colleague Robin, who's also a postdoctoral fellow here. Um, so we have all of our wonderful panelists who worked with us here. I'll encourage everyone and for the first question, just to quickly reintroduce yourself. Um, Without further ado, I'll get started with our first question. So our first question is, describe a little bit about your role in supporting youth and families around their mental health. So from your experience, what do you see as your most valuable and helpful thing your team does for families and youth? And I'll go ahead and I'll call on Lindsay first.
Hi there. Yes, so again, my name is Lindsay. I'm a supervisor for the Children, Youth, and Family Mobile Crisis Team. I see my role as supporting my clinicians and my peers in their contact with our clients and their families and children families. Our team rushes right out to meet the client at their self-addressed crisis, and we walk alongside them. and help them develop a client-directed plan that often involves formal and informal supports and services. We like to collaborate and get creative, use out-of-the-box thinking, and that's why this tool has been so helpful for us. I think the most valuable thing we do is we keep showing up for clients, and we're regularly available 24 hours a day.
Wonderful. Thanks for sharing that, Lindsay. Um, Sounds like you do a whole lot, and your team does a whole lot.
My team's amazing. They're quick to get out to see families, help them identify what their crisis is, and walk alongside them.
Wonderful. Thanks for sharing that. Uh, Curious to hear from Katie.
Hi, I'm Katie, and I am with Seneca Family of Agencies in Pierce County as a crisis counselor and clinician. So I've worked both the MRT rapid response as well as the stabilization side of things. And for me, the biggest thing that we do is we walk with them in crisis. We go meet them where they are in whatever they define as the crisis. And that client defined crisis to me is really important because we don't get to decide that, they do. And we help wherever they are. So we've navigated helping at schools as well as homes and getting to truly meet them where they're at and see them through that crisis event is the most impactful for me and for the families that we're helping.
I love how you phrase that about how people, define their own crises, and even Lindsay both mentioned sort of walking alongside individuals. Really nice. Dwayne.
Hi, thank you. So Dwayne Krishke, I'm with Frontier Behavioral Health in Spokane County as a mental health clinician. And it's a great question because it's a bit of a dichotomy, like what we do. Like everybody said, we want to meet the client and their families where they're at, but there's certain processes that need to take place, like risk assessments and safety plans. So trying to let that family and youth define the crisis, like everybody else has said, and responding appropriately to meet their immediate needs, while also acting as an anchor to like interrupt that cyclical nature of crisis. I've had a lot of clients compare it to feeling like they're really sick and they're finally going to a doctor. And then once the doctor checks them out and says, you're okay, they're like ready to run a marathon. And so we do that through, all of these tools, psychoeducation, access to community resources, and taking on the role of like the wise mind during the immediate crisis and just trying to ground them in that.
Ooh, I love that example of taking on the role of being the wise mind in that crisis moment. And it sounds like everyone has, chosen that they're right. They're experts in how to deliver these skills, but empowering families and kids to be experts on their own mental health and the things that they need to be supported with during a crisis. Just wonderful. And then Danielle.
My name is Danielle Maragos. I am a peer support specialist on the Children, Youth, and Family Mobile Crisis Team through Frontier. So as a peer, my role is based more off of lived experience, but I believe with that too, we provide a level of accountability with our kiddos and clients. Our main goal is to provide hope that recovery and change is possible. Support looks different for everybody. So whether it's connection to resources, just follow-up care, or active listening, that's where I come in. One of the things that I really admire about our team is because we have that clinical and that peer setting going out together, it typically provides like a really nice warm handoff for future stabilization. And the familiarity of having that warm handoff, it makes for a good relationship with your kiddos and clients and parents alike. So that's what I do.
Thank you. Yeah, you all put us through sort of understanding when someone comes in all the way to this warm handoff to, the next level of care. So appreciate you walking us through all of that. I'm going to pass this over to Robin, who's going to introduce our second question.
Yeah, thank you. I really appreciate also, I think your answers really highlight the sort of individual tailoring piece and how that is so critical in order to really feel like you're being impactful for families. So our second question is, how has this training been relevant and helpful to you in your work? And what was your favorite tool or skill from the training? And Katie, I'm going to start with you if that's okay.
This training has been helpful a lot from going out to the stabilization side. So some of the skills are more longer term and you can't do in a crisis setting. Wise mind, you're not going to talk them through wise mind while they're in a crisis. But we learned skills as well, like tip and stop, and the different wise man coping distraction skills that are very relevant and used frequently when safety planning or just de-escalating initially to be able to safety plan. And so those are ones I've used frequently again and again going out on initial calls. And then I've talked more about wise mind and different things, more with the stabilization pieces and some of those more specific skills in there.
Yeah, gotcha. And such an important note as well, right? That like these skills are going to be applicable at different times. If somebody's in a crisis right now, it's not the time to really work on this like long-term emotion regulation. And also, we know that these kids need these skills. We know that they do, because it's not enough to just put a Band-Aid on the crisis. You also have to be able to figure out how to make a difference in their life going forward. And I think that's one of the nice things about that RSS model as well, is that you've got these two different components, and different skills are likely to be applicable in different times. So thank you. Danielle, what about you?
Oh, I've loved this. I utilize it quite often, in particular, wise mind and opposite reaction. And why I think that it's so helpful is because it's kind of a foundation of where you want to go with your kiddo, and it makes sense. It's kind of like what was said earlier. You print it out, you take it, you walk through it with them, and then you have that back end that is kind of the follow up for them to be able to process what they've learned. And I've had some amazing results with it. I'm a
Yeah.
huge advocate for all of it.
Yeah, this sounds like Wise Mind in particular has been one that's stood out for you. And does this stand out for you in terms of like kids or for yourself or both?
Well, for both, I mean, I would think out of the two of them, opposite reaction, at least with my clients. I've had some of them that had never even really thought to do something opposite of what they're used to. And then kind of going back into it, updating parents or whatnot, they're like, that's where they got that from. Like, I got a total different response than what I'm used to. And so that's where they got it from. So I like opposite. I like wise mind too. And it's just kind of deciphering the difference between your emotional and your rational mind and being able to bring them together to make really good choices. And it just clicks.
Yeah, absolutely. I also appreciate it. Sounds like it's helpful to have some conceptualization of like what
Yeah, for
kids.
sure.
Also, just for any audience members who don't know what opposite action is, which is totally fine if that's the case, it's really about in situations that are not like immediate crises, being able to act opposite to the action urges for unjustified or ineffective action urges. So just to like put that kind of like something a little more concrete onto that, if you are really, really anxious about, I don't know, doing a webinar, for example, or something like that, and you're feeling nervous about it, but actually it's not dangerous to do that webinar, being able to go forward and doing it. And even though you have the action urge to like run away and not do it, for example. So thank you, Danielle. That's so helpful and really appreciate hearing about how that has played out for, it sounds like a number of your kiddos.
Absolutely. I always go back to it for sure. It's been very helpful. Thank you.
Dwayne, I'm going to call on you next.
Right. Thank you so much. For me, it kind of goes back to like seeing us as the anchors for the family. And at some point, when they've weathered the storm, you raise the anchor and you go on your journey. These trainings provided a toolbox to overcome the barriers for the clients that would respond with like, I don't want to do that, or I've tried everything. And I'd be able to do that quick grab and go and reference back to this manual and just say, oh, this one, let's try this. We haven't tried anything like this. And because I can't have a direct answer for anything, I have two favorites. For younger clients, I really do like that wise mind and understanding emotions aspect because the younger clients tend to need help communicating their feelings to others, be it a teacher or a caregiver. And then for the older clients, those, leading up to 20, the ABC Please, I really like that because it's a practice model really for them. And practice is progress for them. And it gives them a sense of that locus of control. It comes back to internal where they can find things that they actually own.
Yeah, really appreciate that. And it all sounds like Wise Mind has been one that's come up for a lot of folks. And then ABC Please, again, just for folks who might not be familiar, it's really about kind of reducing our vulnerability to emotion mind. So can be, and just as Katie was pointing out with like, it varies in how applicable that is. If you're right now in a top crisis, it might not be the time for it. And also, can be really important in terms of helping kids like build out that life that they want to have. So really appreciate that. And then Dwayne, you were talking about the handbook being helpful. I'm curious, how have you like used that with your kiddos?
Yeah, so I actually just have a 3-ring binder with everything you guys provided us. And so I can make copies and then just take them out to them and go over that as I know, like Wise Mind, I know. Like I just know how to communicate that one. But the other ones I can grab and go, okay, these other things I've tried haven't worked. Let's go in this route. So it does become, like Katie said, more about the stabilization for a lot of it, but it does help in safety planning too on like that ABC Please. It's like, okay, let's go down this list. I can put this on the safety plan. I can put that on the safety plan. And it just helps kind of round that out. If one thing doesn't work, they have lots of options to return to.
Yeah, I think that's another thing that's an important point and kind of connects to what you guys were talking about with this like individual tailoring piece where not all of these skills are going to apply to every kid. Not all, even if they would work, if the kid wanted to do them, sometimes you just won't convince a kid to do a certain thing. And so having kind of a variety of options can be really helpful so that you can problem solve and help figure out how to tailor it to what that kid is actually willing to do and what's likely to be helpful for them. So glad that having some of that variability has been helpful. Do you have like an example of something where like you tried it and it didn't work and then you like switched to something else?
Oh, absolutely. Unfortunately, I have a lot of examples where it didn't work initially, but one that I tend to go to just even before this training is the sensory grounding, like 5, 4, 3, 2, 1. And then ABC Please is kind of a natural extension of that because it goes back to like sensory things. I think it's easy for me to just go, okay, well, you didn't like that aspect of like basically playing I Spy or whatever it is. And this is a little more mature. That self-soothing one also kind of goes right into that as well as you hit all those sensory inputs.
Yeah, and also appreciate just the highlight about that developmental level of kids. And a lot of these skills are more developed for kind of teen sorts of ages. And you might have to like make some adjustments for younger kiddos for them to make sense, or they might not be appropriate for younger kiddos. But just highlighting kind of like thinking through how the developmental level of that kid impacts what makes sense to ask them to do as well.
Absolutely. Developmental, cognitive development is like huge in where you're going to land on this. So you might see a 20-year-old and you're like, oh, nope, we're going to Wise Mind. And you might have a 9-year-old where you're like, oh, we're going all the way through all of these tools because they're just so advanced.
Yeah. Um, uh, Lindsay, wondering about how this training has been relevant to you.
Yeah, so for me, what I love the most is that the skills were brief and tangible, and that all the materials were bundled in a way that was easy to revisit them with clients, while we were still building our own competency in these skills. That is to say, we didn't have to become an expert first, but we could do these skills with clients and move higher in our competency and proficiency. Um, as you can see, my staff got out there a lot with their clients and used these different skills. I didn't get as much face time with clients to practice them. So most of my practice was in our trainings, and I found it very helpful. Um, but regularly they'd come to me in supervision and say, I tried this one, we're going to try this one next. And not once did I ever hear any of them say, well, those didn't work or that wasn't helpful. It was always helpful. And so while they're the skilled practitioners out there doing the work, and I couldn't always say, well, let's do this and example it for them, I could say, what about those skills? Do we want to try using one of them? And they're like, yeah, let's try that.
Yeah, and I hear also just like kind of like just having this array of tools is meaningful. So even if one, I know you're saying nobody said it wasn't helpful, but like, you know, you kind of have the wrong screwdriver, right? And then doesn't mean that that screwdriver isn't helpful, just looking for the right screwdriver for that particular task. So it sounds like noticed a lot of active use. And it sounds like from your perspective as a supervisor, you could really see how staff are using them. I'm just curious whether or not anybody on the panel like themselves personally practiced any skills and found it helpful.
I personally use stop on a regular basis because I need to sometimes and just take that breath, right? And then think through like what's actually plausible here in this moment and not react so emotionally sometimes. So I guess wise mind as well.
Yeah, absolutely. Finding a moment to kind of like step back from that crisis urge is also something that you found to be helpful. I know many of us probably use various skills. I was just curious if there was anything that stood out to folks of something that they personally found helpful in the context of like working with kids, which is a stressful thing to do. This is stressful work. Well, thank you guys so much. I'm going to turn it back over to Carlos.
All right, everyone. So we, talked about, your favorite tools and skills that you learned from our training. Um, Now I'm curious, as we expand access to care and grow these mental health crisis teams in Washington, what do you think would make this type of consultation training program even more effective? And I'll start with Danielle.
Well, I remember this question from the poll, and I still have the same responses I did then. I think that parent management training would be very helpful. Also, in the sense of like guardianship, foster parents, caregivers along those lines, just more insight on how their own behaviors could be affecting their child's crisis and how to mitigate that. I think that sometimes because there isn't that biological connection, that after multiple attempts of trying things and not really being skilled in that, you see a lot of defeat, a lot of overwhelming and just kind of giving up and throwing hands in the air. And I think to be able to provide some type of guidance with that on our end in those situations would be super, super helpful.
Yeah, so it sounds like helping parents, promote a supportive and positive environment for our kids that are, tend to be sensitive to experiencing certain emotions.
Right.
Be really helpful.
And sometimes the parents can be the contributing factor to the crisis, and they're not always aware of that. So just more insight in that area.
Mm-hmm.
Yeah.
Sometimes we're all trying our best, and it sounds like some insight on how we can make things fit better.
Right. Yeah.
Wonderful. Thanks for sharing that. I will go to Katie next.
I love that idea of having stuff specifically geared towards working with the parents. I also was thinking something more geared towards some of the younger kiddos that we work with. We've lately, here anyway, seen a lot more 8, 9-year-olds, and the same things that apply, or doing the skills differently with them. I think would be helpful to loop that in a little bit more. And then from like a logistical standpoint, doing more of the trainings in person would be nice, just because then it's easier than on Zoom, as we did most of ours that way anyway. As well as the logistical standpoint, having someone else, maybe outside of the direct team that you're training, holding the phone, as we call it, helping support the line as we're in it, would be helpful. But those are more logistical standpoints. But I love the idea of bringing in the parents, as well as how to help the younger kiddos. and maybe something specifically for like school staff for helping within those settings too. So we do a lot of school calls.
Yeah, and parents are always a great way of helping when, right? When we talked about this developmental level of working with younger kids. I'm curious if you had any thoughts on how to support younger kids or support with the school system that you were specifically interested in.
I just know sometimes different school systems make it harder to include some of the skills that we want, or the school staff themselves aren't trained in the skills that we're trying to help teach and mention to the kiddos. Most school staff are very receptive to like our responses and our suggestions, but sometimes there'd be more pushback of like, oh, we can't do that, or it's not possible to do that. And just having a better way to kind of to work around and manage some of the restrictions that schools sometimes have just due to that setting being different. Um, with younger caregivers, with younger kiddos, caregivers typically are super helpful with what they know does and doesn't work and are receptive to a lot of our comments. I know with younger kiddos, I've mentioned tip and dunking your head in water. And sometimes I've mentioned it with like, you can do it with mom, pull mom and she'll do it with you. And typically the kid's like, oh, if they're going to dunk it their head with me, then I'll do it. And so like bringing in that and like utilizing the whole family component has been helpful with younger kiddos. So just kind of expanding on how best to, it's that maybe if that family has also a difficult family component, it's harder to loop in the family, and how best to help those younger specifically in like those instances, I think would be interesting to expanding it to learn more of.
Certainly, yeah. So modeling is wonderful, and kind of especially with younger kids, being able to do skills with them and rather than just providing instructions can be really wonderful. And then yeah, building out those partnerships with different organizations and institutions like schools, right, that have their own parameters and knowledge of some of these skills and how you can weave those with existing resources. Wonderful. Thanks, Katie. I'll go to Dwayne next.
Thank you. I really think Danielle and Katie kind of hit it on the head, getting the adults involved. And consistency is key. So kind of bridging that gap between school and family, that's huge in the communities. I think probably everybody on here is aware of that. And so if we're speaking the same language and using the same tools, even the same terminology and calling it the same thing, right? Those skill sets will be vast in making progress so that they have that consistency in their life. Because really, when we're in the crisis mode, that's what they're seeking is just consistency. And it helps to even just use the same words across the board.
And I love that idea of consistency. I know in my own work, you sometimes see where people develop safety plans in different settings, depending on who they're seeing. And they all are trying to achieve the same thing, but using different language and different versions and formats. And so working together to have one thing that kind of works for everyone sounds like it would be an optimal solution.
Yeah, absolutely. I mean, we see it when, parents live in different homes or when parents live in the same home, even where they're going about it different ways. And it's good to have two people thinking a little differently, but that kid needs consistency often. So
And alignment on sort of where to go next and what to do.
that's a great phrase for it. Yeah, thank you.
Thanks, Dwayne. And then I'll turn to Lindsay.
Yeah, I don't think we're ready to be done with this program yet, honestly. Like, I think it would be helpful if we could continue to engage in some points in the future, either by survey on how we're doing, or if we can still participate with new teams occasionally. My fear is that if we're not continuing to engage in the material, that we may slow down our use of its skills. As a supervisor, I think it might be helpful. In terms of keeping the content current in our minds. And if there is a train the trainer format in the future, so I can continue to bring on new staff and bring them up to speed or have them join new versions of this going forward, I think that would be helpful.
Thank you. First, so affirming to hear that. So thank you. And it sounds like continuing with consultation or this like train the trainer format, thanks for calling that out, is going to be sort of essential to this long-term success of being able to
I think it would be at least even like just a regular discussion about how it's going or something to keep it in our format because it can be so hectic and we can get so busy in the processes, right? Did we get the safety plan? Did we check all the boxes? Did we do this? Did we do that? That I think continuing to have this kind of in-service level where we're reevaluating our skills and reapplying them in new ways, I think is super helpful for clients.
Certainly. So continued check-ins.
Yep, we really enjoyed it.
Thank you. Robin, is there anything else you wanted to add?
No, I think we can turn it over to Kirill, who's going to talk about next steps, which I think hopefully at least some of will be exciting for our panelists.
Yeah, excellent. Well, thank you all. I mean, round of applause for you all. Our panel, just really awesome. And we so enjoyed working with you all and collaborating on putting this together and kind of your feedback and your engagement throughout all this was just such a huge part of what hopefully made it as effective as it's been so far. And let's think through some next steps a little bit that we wanted to share. So, number one, we're definitely reviewing the feedback, all of your feedback, and kind of combining all the feedback across the many different sessions that we did. Again, with this like another iteration of refining the program content, making it as smooth, adaptable, flexible as possible. Um, and then planning for a second phase, again, it's good to hear that it feels like there's still definitely room and interest in continuing even what's already been done to kind of deepen and embed those skills and this content more. So planning thoughtfully for a second phase, taking everything we learned from this past year of implementation and planning for a second phase of implementing this with an emphasis on much wider reach, much more sustainability. I love hearing these ideas about train the trainer models and other ideas and approaches to sustainability and increased access. More importantly, I've seen already a few people ask in the Q&A, how do we sign up for this? How do we get it? That's really what we're deep into plotting next is how to increase access far beyond just our wonderful pilot partners. So those are two big steps we're working on now. And then this third one, and I think this one really hits on a few important things that was discussed in our panel. I heard several of you say, let's bring the parents in more, even more so than these skills we're able to do. And let's even design some stuff specifically for parents because they're such a crucial part of the supports and the interventions and the community-based strength for a lot of the clients that are struggling with their crises. And so we're really have been pretty actively developing and workshopping an asynchronous parent and caregiver skills training program. And this is something that's really exciting because we've partnered with NAMI Washington and caregivers with real lived experience who are engaged in this co-design participatory process with us and giving us ideas and input as we are adapting some of the, I heard people say parent management training approaches. So we're drawing on those, adapting them, especially for parents and caregivers who are, not just parenting, but parenting in the heat of some really intense crises and risky moments. So adapting there, but again, also really, really bringing the parents' real lived experience and voice to the table at the early stages of the design of what we're making. And the asynchronous piece is something that I'm excited is going to increase access and just make it really accessible, on your phone, online, on a computer, and also hopefully something that will be accessible to MRSS teams as well for you all to be able to access and see what it is and help go over some of this stuff using the asynchronous platform that we're envisioning with parents, give it to them to work through independently, any blend of those things. So yeah, this I could just talk about this forever because it's a lot of exciting next steps that we're thrilled to keep working on, but that's where we're headed next. So with that in mind, I will turn us over to our Q&A. I know we have some great questions in there, and over to you, Winslow.
Thank you, Krill. And Thank you, everybody, for attending today's session. Carl's right. We got some great questions in the Q&A that I'm excited to run through here. Also got some questions in the chat. So thank you to everybody who submitted questions. Feel free to keep submitting them. We do have some time now to pose them to our wonderful group of hosts and panelists. So Carl, actually, if you don't mind sharing the screen again, I did just want to show folks one last slide there. It actually relates to one of our questions. So how do you contact Krill Gerdevenko? How do we contact Lindsay Galvin White? Michelle is wondering. Um, yes, well, here you go. Contact info for everybody who appeared during today's presentation. I know that I speak for everybody on the call. We'd love to hear your questions, follow-ups, anything you might be wondering about that folks have discussed during today's call. So thank you so much, Michelle, for that question. Encourage you to get in touch. And we did field a few questions just about MRSS in general, just as a model for service. So I want to start with this one, also from Michelle, asking about the age range that MRSS serves, what areas does it cover, and how to reach the MRSS team to get in touch for a consultation. And Betsy also asked what age groups and what service areas do you serve within these programs. So why don't I actually start with Krill, maybe just to give a quick response to broader MRSS across Washington State, and then we can go to Lindsay to hear about how it's playing out in Spokane County. Okay.
I feel like Lindsay and our panelists are best speaking to, what age range, what area, how to get in touch. I'd love to punt this one to our panelists, which do this every day.
Yeah, so people are free to call 988 from their phone, and that will get them into a hub that will be a safe place and person to talk to. And then based off that call, clients are being referred to a safe person to respond, which is what the CYF team is, also formerly MRSS team. So that same concept to people in crisis. So not every county has this program in place. Some of the counties are covering all ages. Some of them are specific to youth. Here in Spokane, we work with people not yet 21 in a self-defined crisis, but we have a counterpart just on the other side of our office that works with 21 and over. So these programs are coming online in most counties, I think, in Washington. I just don't know the rate at which that's happening.
Great. Thank you, Lindsay. Katie, anything you would add from y'all's team? Any differences, or just to give a sense?
Yeah, so we get calls from Crisis Connections, which can go through 988 as well, and then they get routed to Crisis Connections, but there's a more direct number through Crisis Connections. There's a specific Pierce County and King County number, as well as I think a more broad Washington number. And Seneca works within Pierce County for it. We work with Catholic Community Services, also serves youth in Pierce County, and I think Multi-Care serves adults. And so we serve school age youth, so typically up to 18. If they're still engaging in school services and in school, then we would serve them. And I think we have helped with a youth who was as young as 3 or 4. And then that again is more helping the parents at that point. But we've all kids up until around 18 is what we serve in Pierce County. But adult services exist as well.
So check your county is the answer also.
Perfect. Thank you, Lindsay. Thank you, Katie. Great responses there. We fielded a few more questions just about MRSS in general, so I'm going to ask those to our panelists and hosts first. So this one comes from Tracy through the chat, wondering, during crisis with a client, does a whole team go out together? So just the service delivery format, any notes about that would be very helpful. Maybe we'll start with you, Danielle.
So it's typically through our program, best practice is a clinician and a peer. Sometimes that's not always available. And then, like I said, it provides that warm handoff and transition after the initial assessment.
Perfect. Yeah. And is that consistent kind of with how Seneca usually responds to those calls, Katie?
Yeah, best practice has a clinician and a peer. Sometimes in hospital settings, just a clinician will go, but that's only if we can't also have a peer. We typically have both.
Great. Thank you. Great question. Thank you for that question, Tracy. I'm just looking through the other questions we got. And again, thank you so much for submitting these. Another question more just on the MRSS model. Michelle is wondering, is there a limit to the number of times you can go through MRSS? Does it require a referral from a school or organization? So yeah, would love to hear thoughts on that from our panel. Lindsay, do you want to get us started there?
Yeah, again, so 988 is a nationwide program. Dialing 988 from your cell phone is going to get you to that first step of getting connected to a safe person, and then hopefully referral to a safe person to reach out in your county, in your area. And so that is the referral process. Anyone can make a referral at any time for any reason. A kiddo themselves can have a self-defined crisis. Parent can have a self-defined crisis regarding their kiddo, what have you. So it's really as simple as dialing 988 just to kind of get things started. They're going to want to kind of talk you through it and address that way. But if you're asking for someone to respond when you make that statement, they should help facilitate that as soon as possible.
Perfect. Thank you for clarifying that, Lindsay. Super helpful. And thank you for the question, Michelle. Great. I'm seeing more questions come in. And as I just look around here, wonder if we could just maybe clarify a few other questions that we received from our audience, specific to the training. So, Carl, maybe I'll throw this one to you first. Celeste is asking, how do we access the training modules? Is there a cost?
Yeah, great question. So I think we're kind of in the thick of, or about to be in the thick of designing how to increase access. But as far as I know, there is not going to be any cost. We're going to try to make it freely and easily accessible. So stay in touch. You know, we shared our contact and yeah, stay in touch and we'll try to announce once we have a plan for the next phase here. Maybe I'll jump into great question. There's another good question in here that also asked, are skills taught directly to identified clients or in conjunction with the caregivers so the family is learning? And I will say this question excited me because we've really tried to emphasize and model the idea that it's highly flexible. So all of the above, right? Like you could absolutely pull this content and deliver it to the family as a group. And I'm assuming the panelists would agree that that varies greatly from client to client, right? There's some families where the parents really want you to get in there and work with just the kid, and they're not quite ready for learning themselves. They're overwhelmed. They just need the help with the kid directly. That in that case, I assume you're focusing more on that. In some cases, the parents want to know too, and you can do the skills training and application with everyone together. In some cases, the kid is the one that's not quite ready and just needs the de-escalation and a break, but the parents are the kind of more immediate receptive targets for some of the skills training. So yes, all of the above, but again, pending, you know, most importantly, tuning into where the client and the family is at and what's going to be most effective for them. Yeah, sorry, I just jumped to another question, but back to you, Winslow.
No, I'm glad you touched on
Yeah.
that one.
I'm
And
curious if panelists have, you know, if panelists have thoughts on that. Do you teach to everybody together, separately, a blend of the few? Um,
I mean, in my experience, it's been individual basis, just like you said. Um, it comes with whoever is ready to learn and wants to. And exactly like you said, sometimes it's the parents, sometimes it's kids, sometimes it's the family unit, and sometimes it's both just at different times because we do, you know, go up to 8 weeks of service, and sometimes we go up to 8 weeks, and 2 days later we start again because that's just how it goes sometimes. So it's just where they're at currently.
Yeah. Thank you, Dwayne. I really appreciate that response. And um, if any other panelists, Lindsay, Danielle, Katie, if you'd like to sound off on how you've applied these skills in the past, whether it's just to the youth or to the caregivers or both, feel free to come off mute. It's definitely an interesting question.
I am the same with as Dwayne. It's individual one-on-one. I've never really introduced it to the family unit like that. And kind of like Dwayne said, a lot of it is willingness to want to learn. I mean, I think maybe moving forward, it might be something for me personally to consider because it could be very helpful in bringing the whole family together and showing them, going over the different skills that would be helpful.
Definitely, yeah, yeah. It's that tailoring just makes a lot of sense, right? Meeting people where they're at, and not trying to extend skills into situations that would not be a good fit. Well, I actually have a related question to that from Celeste that came from the chat. It was asking about co-regulation strategies to help kids and family move back into their window of tolerance so they're more receptive to skill. So would love to hear panelists' thoughts on that. I think it's a really interesting question. Um, who wants to get us started? I would love to maybe let's hear from Kirill first, just as like more the part of the team designing this clinical content, and then we can hear from the teams how it actually went in application.
Yeah, I mean, I think this is another one that really varies from family to family what co-regulation means, or even if it's possible, right? I'm guessing from the panelists, sometimes you show up, and often that's part of the issue and why the crisis is happening. That boy, co-regulation is just not on the table for this moment, and we just need to stop things from getting worse. But I'd love to hear from you all. What have you done to help families get a little bit more co-regulated and stabilized into a place where they're open and willing to try something new?
That's typically when I bring in tip or something that doesn't take a lot of thought to help them regulate before we then talk about everything else. Tip is kind of a go-to, or stop, distract. I always have fidgets with me. Something else to kind of distract has been the most helpful in those instances right away.
I think as an introduction to it, a lot of times in that immediate crisis, I tend to try and find common ground first so that we can reach that level of introducing skills, like Katie said. And sometimes it's just acknowledging everybody's input and then being able to open up to these skills.
I know for me personally, as a peer, I think what's been most helpful is just the building of rapport to where they feel comfortable enough to be open and vulnerable and receptive to the skills itself. I don't typically just dive into it. And I think a lot of it is age appropriate because and some of the skills might not be as helpful for a 6-year-old as it would be for a 15-year-old. And so that's when I kind of bring it back down to I do a lot of feather breathing exercises where they have that visual feather. And so it's more age appropriate at that time. But I think a lot of it is just about making it a safe place and safe space to be vulnerable and open to new skills.
Yeah, I imagine just somebody showing up in a timely way, right? Like that's the first step of co-regulation, just for the system and the environment in general. Like you guys just showing up, being regulated yourselves, and yeah, that there's somebody that cares, that listened, that showed up. I mean, yeah, that's probably so much of it. Thank you all for doing that.
Absolutely. Thank you all. Very thoughtful responses. And thank you all for submitting these questions. I feel like we're maybe getting more than we can answer within the next 7 or so minutes. So just want to warn folks of that, I guess, ahead of time. We'll definitely try to get to as many as we can. So Thank you. I did want to direct one back to Robin and Carlos and Krill, our DBT therapists on the team. This question from Melissa asks about DBT skills being just one component of DBT therapy as manualized. And so, how would you recommend that we talk with youth and families about DBT? And when? Why would they want to continue with DBT therapy? Why might they want to continue with DBT therapy? So Robin, do you want to get us started there?
Yeah, one thing to highlight is we're using DBT skills as a component of this training, and we are not training these clinicians in how to do full model dialectical behavior therapy, which is kind of a complicated and multi-component therapy. And part of the reason that we're adapting it is because it's not always feasible to be able to make something like that happen for the number of families that are in crisis. So full model DBT is a 4-component model that involves individual therapy, a multifamily skills group for teens, it's multifamily, phone coaching, so 24/7 access to your therapist to get coaching when you actually need it, and then a therapist consultation team where we really kind of like hold ourselves to making sure that we're providing the model adherently. DBT is supported for, it was developed for sort of like suicidality and self-harm, but it's also supported for other concerns that are rooted in emotion dysregulation. So when emotion dysregulation is really the concern. At Seattle Children's, which is where Carol and I are part of the DBT team, we really are serving families where suicide and self-harm are major presenting concerns. I know the question also asked about IOP and PHP. I just also want to just note that standard DBT is actually an outpatient service. So it's not necessarily at a PHP or IOP level of care. So just a note about that. But I would say for families that you might want to refer to DBT would be families where there's kind of chronic or long-standing suicidality or self-harm, and where other types of treatments haven't worked. And an additional like set of supports is likely to be needed to help make sure that they can move forward. Carl, did you want to add to that?
Yeah, that was a really nice description. I'll just add that I think you nailed it. And the access to full model DBT is just really, really hard, even though DBT was developed in Seattle in the state of Washington. Um, I mean, we can recommend and refer people to DBT all day long, and many of us do. But first off, and it links to another really good question. Um, uh, First off, there's very, very few. I mean, I think Seattle Children's and maybe like one or two other places in the entire state are have a full fidelity DBT program that don't exclude based on insurance or are not out of pocket. And even when we have more of those programs, again, the demand and need for them so greatly exceeds the spots because it's such an intensive treatment. So while what we're doing here certainly does not replace full fidelity DBT, we are really excited because it's just a much more scalable, feasible way for some of the active ingredients of DBT, some of the things you've heard our panelists reference, all these skills, to get out in a much more flexible, sustainable, tangible way, even though it doesn't replace kind of the full thing, which certainly a lot of folks will still benefit from. So, in terms of just practical ways to talk about this, is if you're seeing even one of these skills helping a family or a client, that's your foot in the door. Just to say, hey, some aspects of this seems to be helpful. Let's see if we can get you connected to some more resources or some more content from this treatment or this set of interventions. And I will say it doesn't replace the full model, but there's growing and growing resources online to be accessed asynchronously. There's a lot of great YouTube skills training videos. Again, it does not replace, a really quality sensitive team that can tailor and individualize this, but yeah, there's some ideas there.
Yeah, I mostly just highlight because I think it is important that, like, from an informed consent perspective, that kids don't think, oh, I already got DBT when they didn't.
Absolutely. Thank you, Robin. Thank you, Carol, for such thoughtful responses there. It's a really great question from our audience. Um, I'm looking at the time. I see we have a few more minutes, but I do just want to take this opportunity, in case we don't get it again, to say thank you to everybody for attending today. Really appreciate all your thoughtful questions, your attention, your time on this Friday. We all appreciate it a great deal, and also thank you to our wonderful panelists, Dwayne, Katie, Danielle, and Lindsay for giving their time to today's presentation. I just want to say thank you again. I know our team is going to pop a survey link into the chat where you can give us some feedback on the webinar that you attended today. And so we'd love to hear your thoughts on everything that you heard during today's session. And this is the best way to do that, is to respond to this survey link. And I'll just throw that into the chat for folks right now, just so everybody can access it. In the meantime, Crow, I wonder if you could maybe step in with facilitating any last thoughts from the panel, from the hosts. Get us kicked off with that, as we're saying goodbye during today's session.
Yeah, no, just a big thank you to our panelists, and just thank you for all of your amazing work. You've got the feet on the ground, and we're just so grateful for the work that you're doing. Yeah, and I know there's a lot of great questions in here, some of them very practical about how to access this training, how to access these resources. Please follow up with us. I'm so sorry that we're out of time. But I think the good news is that the answer to many of these questions about how do I access this, is this required, is that required, is my teenager have to be in the house to get parent management training? The answer is no, right? We want to make this as accessible as possible and minimize any unnecessary barriers. We've done parent training for years with lots of parents whose teenagers are out of the home or are getting higher levels of care or whatever, for whatever reason. And that's not a good reason to prevent parents from working on things that they can do to make things better. So just follow up with us and we'll do our best to answer some of those questions. I know we didn't get to everything, and just thank you for everybody's thoughtfulness and presence on this Friday now afternoon. Really appreciate it.
All right. Well, that brings us to the end of today's session. One last big thank you to everybody, and hope everybody has a good rest of your Friday. Thanks for joining us.